10 years since we had the first study showing cardiovascular benefit for a particular drug in diabetes coincides with 10 years also of growth of diabetes care in the country. We're looking at a full room. Our first conference was started off as a half-day meeting, and our sponsors for this particular session happened to be our full sponsors for our first meeting back in 2015. So that time we had Dr. Kunia, Dr. Paul Ngugi at the helm. We had a half-day meeting with the gynecologist. Professor Ndavi was there, I remember. So there's a special gentleman we have to acknowledge. Where is Godfrey Ayuka? Godfrey? Is he here in the room? The man with a very nice pinstripe. Let's give him a big round of applause. So from a half-day meeting, look at the room. Fully packed. 10 years down the line, thriving society. We've had excellent leadership from Dr. Kunia. Stand up, please. No, you have to. And now we have our new president, Dr. Rosalind Ngugi. Stand up, please. She's done an excellent job with all the logistics of getting us here. So I'll invite my panel members. I'll start with my good friend, Dr. Mohamed Abdullahi. So he's a consultant physician endocrinologist who is going to give us aspects of SGLT2 inhibitor use in the setting of diabetes. That's where the drugs were first used. Then there's Dr. Mohamed Jeilan, who is a consultant physician, interventional cardiologist, started off our program with regard to cardiology fellowship in Aga Khan, and he's done an amazing job, and he's also my former teacher. We'll give him a bit of time to get to the stage. He had a recent Achilles tear, but he's still going strong. He actually managed to run an entire conference at STEMI with over 600 delegates, and he still did it. So he's definitely a man with a lot of ambition. Then I have Dr. Joyce Bwombengi. She's a consultant physician and nephrologist working at Aga Khan Hospital. Good friend of mine. So we're going to kick off the session right now. I'll give the... So we'll kick off the session. We have 30 minutes. Where's our timekeeper? So I can be able to keep track of them. Timekeeper, that'll be Olive. But I just want to take, before you start the time off, so we've taken 2 minutes, but you'll add me just 3 minutes. So I just want us to take time to just pay respect to a colleague who we lost, who worked in Aga Khan with us, Dr. Alan Rajula. He was my good friend. So let's all stand up and let's observe a moment of silence for Dr. Alan Rajula, who will be buried on Saturday. His mass is actually being done today, and we were not able to attend because of the conference. So let's please, can put our time, we'll look at 1 minute. So 26:38, 1 minute of silence. Thank you. So thank you. May you rest in peace, and let's all be seated. So we'll now start our session, and we can now reset the time. I'll look at, don't worry, we'll just use this, I can see it. So it's been 10 years of using these wonderful drugs. We're now going to go through this particular class of drugs, the SGLT2 inhibitors. We'll look at class differences. We'll look at their use, where their origin was in diabetology. We'll look at their benefits and their history in cardiology. And we'll look at it in chronic kidney disease. So, Dr. Abdullahi, walk us through where we started, how these drugs made a huge influence in clinical practice with regard to diabetes, and then tell us what are the other clinical trials and what's the evidence that has showed us that these drugs do work. Thank you so much.
Thank you very much, Erick, for the introduction. It's been 10 years of SGLT2s, so we'll take a look at a bit of why we need to treat diabetes. Then we look at the history of SGLT2s. Where did they come from? We look at a few studies, cardiovascular outcome trials, then after that zero in on one of the trials, and then from there I'll hand over to the rest of the team as we cover the cardiovascular continuum. So the objectives of the presentation include what is there on the slides. We look at the burden of these cardiorenal diseases. We look at specifically the journey in type 2 diabetes, in heart failure and CKD, and then how do we manage these patients, and where does SGLT2 fit in across the guidelines, and what are the practical implications to clinical practice. So why do we need to treat patients with type 2 diabetes? The reason is, as projected there, is that diabetes is associated with a lot of cardiovascular and renal complications. More than 50% of our patients develop macrovascular disease within 10 years of official diagnosis. Of this, about 44% of all new renal failure patients occur in type 2 diabetics. About a third to 40% of all diabetic patients beyond the age of 40 have diabetic retinopathy. And nearly 60% of all non-traumatic amputations occur in type 2 diabetes. About a third of all patients with diabetes have an increased risk of hospitalization for heart failure, and this is at 4 years from diagnosis. And about 72% of our patients have an increased risk of ischemic stroke. About a fifth of this, usually beyond the age of 65, die from stroke. And about half of our patients have an increased risk of MI compared to those without type 2 diabetes. Diabetics are 2 to 4 times more likely to get an MI compared to non-diabetics of the same cohort. So the modern practice of diabetes has shifted away from glucocentricity. Now we are looking at these complications and how we can be able to delay or prevent these complications. SGLT2s have a long history. They came from the bark of the apple tree, as you can see there. What was derived there was the fluorescein. Fluorescein is what led us to the SGLT2s. So the discovery of fluorescein goes way back to 1835, when it was noted to cause glucosuria. But this was initially later, about 60 years later, it was shown now in human beings that if you take the fluoresceins, then you are able to pass urine, glucose in urine. And this did not, later in about the 70s and to the 90s is when now we were able to discover the SGLT2 receptors. And it was not until the later part of this century that we were able to hypothesize that SGLT2 inhibitors can work in the treatment of diabetes. And it was not until about 2010 that the first cardiovascular outcome trial came out. And what was really presented and approved for use initially was the empagliflozin, which was in the EMPA-REG trial in 2015. This was followed by now the dapagliflozin trials, the DAPA-HF in 2019, and the DECLARE just before that. So, but the first one to be licensed for use was the dapagliflozin in 2012. So how does SGLT2 inhibitors work? So what they do is they reduce glucose reabsorption in the proximal tubule. And this allows us to increase urinary excretion of the excess glucose, which comes to about 70 grams a day, corresponding to about 280 kilocalories. So you are able to remove the glucose and the associated calories, And what is there is that the SGLT2 selectivity is much more in the proximal tubule compared to the SGLT1. So based on these findings, there have been quite a number of cardiovascular outcome trials. I'm just mentioning a few of the bigger trials that have been there in the past decade. And this includes the EMPA-REG trial in 2015, the CANVAS trial, and the DECLARE-TIMI trial. If you look at the highlighted area, looking at the study populations, you can see that the DECLARE trial had only about 40% of patients with established cardiovascular disease compared to the EMPA-REG, which had nearly virtually all the patients having established cardiovascular disease. So the DECLARE trial looks more like the real-world patient that you will see, that much more of our patients have major risk factors than those ones with established cardiovascular disease. So looking at the trials, they looked at the similar primary endpoints, looking at the MACE, and also they had some important secondary endpoints, which was really looking at the renal angle, looking at the all-cause mortality, looking at heart failure, and looking at all-cause death. So based on those trials, then the question is, how good is SGLT2s in glycemic control? As you can see from one of these trials, is that dapagliflozin has shown significant reductions in HbA1c when used as an initial therapy or as an add-on across the board. As you can see from the slide there, irrespective of the baseline HbA1c, you can see that there is reduction in HbA1c across the board, and the range is quite diverse, averaging from about 0.8 to about up to 2% in patients who have combined therapy with GLP-1 receptor agonists. As well as HbA1c reduction, the SGLT2 inhibitors also have a significant role in weight and BP reduction. So the average weight loss in most of our patients is about 2.4 kilograms, compared even to the DPP-4 inhibitors, and a blood pressure reduction of about 3.5 millimeters of mercury, compared also to DPP-4. So if you look at SGLT2 versus DPP-4, it shows that the SGLT2 inhibitors have a better beyond glycemic control, let me say that, effect compared to DPP-4s, which are cardiovascular neutral. So would you consider using an SGLT2 inhibitor before a DPP-4 inhibitor? That's a question that I put out to you. But based on some of this data that we have here, it looks like SGLT2 inhibitors are better, especially if you are targeting weight, if you are targeting blood pressure control. If the patient has cardiovascular risk factors, then an SGLT2 inhibitor should be ahead of a DPP-4 inhibitor. So based on this, all the international organizations, including the ADA, the EASD, all recommend that the choice of second-line therapy should be based on the assessment of the atherosclerotic cardiovascular disease, heart failure, or CKD. So apart from metformin, then if there are any indicators of either atherosclerotic cardiovascular disease, heart failure, or CKD, then you need to use medications that have a proven cardiovascular benefit or proven benefit in terms of renal protection. This also goes to all the other associations that are out there, the diabetic ones and the cardiovascular ones. Since 2015, approvals from all these associations in Canada, ADA, Europe, America, all of them recommend SGLT2 inhibitors for patients with type 2 diabetes and heart failure.
So thank you so much. So, Dr. Jeilan, we've seen the benefits. The drugs started off in the field of diabetes. We've seen the benefits in terms of 3-point MACE reduction, all-cause mortality, low risk of hypoglycemia, benefits in weight loss, and an addition to our first-line drug metformin, and can be safely used with insulin as well. So these drugs caused the hype in diabetes. So when did it impact the field of cardiology.
No, it's excellent, and I like the slide that came just before, which showed the endorsing associations. And you'll see from this slide here that the diabetes associations were a few months prior to the European Society of Cardiology. And this is 2015, 2016. So I'll jump ahead and just emphasize something. The EMPEREG 2015 trial was spectacular. It was spectacular for a variety of reasons. The first thing was that it was a diabetes study that had cardiovascular outcomes. We hadn't seen this before. And the outcome benefits were spectacular. We're talking about a 35 to 38% reduction in not just hospitalization for heart failure or cardiovascular death, but actually all-cause mortality. I mean, it's really, really difficult to find molecules that can do that to people. So we woke up when we started seeing that cardiovascular outcomes were improved as a result of this. And what was more emphatic was that two subsequent studies, the CANVAS study and the DECLARE TIMI58 study, showed us the same thing. They showed us that these drugs have at least a class effect. And I'll talk to you a little bit about this particular study, the DECLARE TIMI58 study. Type 2 diabetics above the age of 40. Again, not all of them had established cardiovascular disease. But in this general population of diabetic patients, half of whom received a placebo and half of whom received dapagliflozin, there was a significant improvement in the cardiovascular death, MI or stroke, and in hospitalization for heart failure. And the things that struck us about these molecules were three things. The first thing was that it reduced hospitalization for heart failure. These are diabetic patients. About a third of them have heart failure. And the reduction in hospitalization for heart failure was a bit baffling. Why are we looking at this in the first place? The second thing, of course, was a cardiovascular death. But if you look at the Kaplan-Meier curves, these curves separate within 30 to 40 days. The benefits are realized so quickly. And these are in diabetic patients. And I remember 2018, I think. In 2018, we invited John McMurray to the African STEMI Congress. I think you were there, Erick. And he was telling us that he was about to release the data on the DAPA-HF trial. So we woke up and said, well, what about if the patient doesn't have diabetes? They just have heart failure. Now there's an interplay. About 30% of people with diabetes have heart failure, and about 30% of people with heart failure have diabetes. So you can't have a study which has heart failure patients that doesn't have diabetics. But it's important to know, if you do have heart failure patients with or without diabetes, what will happen? 4,700 patients. This is after Euperio was invented, drugs that are pushing the boundary on heart failure management, and many of them were already on established heart failure treatments. Maybe I'll take a step back and remind people about heart failure, because there's a diabetes group. Heart failure is a spectrum. People have weak hearts, or they can have stiff hearts. You can have a normal ejection fraction or a reduced ejection fraction. Most of us had really good ways of managing people with a reduced ejection fraction. Over and on top of that, we were trying to see if we could improve the outcomes in this group. The DAPA-HF study was the first gliflozin study to be published on pure heart failure patients. And likewise, we were seeing the same sorts of things. A reduction in heart failure hospitalization, a reduction in cardiovascular death. This is the first time we could do better than the three standard drugs that we were using: ACE inhibitors or RAS blockade drugs, aldosterone antagonists, and beta blockers. And this was a drug that was initially invented for diabetes. And the thing that's really stunned us is that up until 3 years ago, there was nothing to treat the heart failure patients who had a normal ejection fraction. We would have to just document that they had heart failure using the various techniques for diagnosis. And the ejection fraction is normal, but we didn't know what to do about this. Somebody said, well, let's see if dapagliflozin can improve outcomes in these patients. The DELIVER study looked at patients with an ejection fraction above 40 and all the way up to an ejection fraction above 70. So mildly reduced ejection fraction to very good ejection fraction, strong hearts that are a bit stiff. 6,000 patients, 10 milligrams of dapagliflozin again versus placebo. And we found a drug that actually improves outcomes. This is the only drug that can improve outcomes, or this is the only class of drugs that can improve outcomes in patients with heart failure, with a preserved ejection fraction. And again, just like with every other trial, you start to see benefits within 2 to 3 weeks of starting the molecule. Now, one thing that people ask, is this a class effect or not? The thing that I'd say is different about dapagliflozin, and it's important, we probably should have had a slide to declare our interests. This is a sponsored presentation. But what I'd like to emphasize about dapagliflozin is that while the clinical benefit reduces as the ejection fraction improves in many patients with heart failure, using other molecules, we could see this benefit continuing even in patients with an ejection fraction above 60%. So people with strong hearts that are stiff. About 50% of heart failures have strong hearts that are stiff, and 50% of heart failure patients have weak hearts. So we're talking about something that was untreatable in many patients, and we can now start to offer them something. I think I've emphasized the importance of these molecules because they can work across the ejection fraction range. And maybe I'll just close with this slide, which is to try and understand, or to help us understand why these drugs work in heart failure. On the left-hand side, you can see that there's a reduction in volume and a reduction in the filling, which reduces the stiffness, and the afterload on the heart. And the energetics of the myocardium are improved. And that results in some improvement in the shape and performance of the heart. And I think I'll stop there. Thank you.
So thank you for that. So maybe just for 1 minute, since now we are here and we have a range of different cadres, you've given us about the benefits across the board, preserved, moderate, and reduced ejection fraction. Just give us a 1 minute comment in the setting of acute decompensated heart failure, their role, and post-myocardial infarction.
Okay, so that's a good point. Acute decompensated heart failure is patients who have maybe heart failure, but something's happened to them acutely. These drugs have only been in our realm for about 10 years, but we started trying to figure out in the acute setting whether we should be using these drugs. The patient comes in, how quickly can we start the drugs? Now, you'll probably talk about safety of these drugs in different scenarios, and we do know that in certain starvation states or states where patients are about to go for surgery, there's a concern about this. But in acute heart failure, these drugs work and they're effective at an early stage. So starting these drugs in acute heart failure is quite effective. In the post-MI patient, the studies have been relatively unclear. It's not yet as emphatic that we should be starting them immediately. In most cases, we start them about 7 to 10 days after the MI, but not in the acute phase of the MI.
So very, very key take-home point. So
Effectively seen from all the studies that have been discussed so far is that, first of all, I must start by saying, number one, we know in our country we've had a growing crisis of chronic kidney disease. Initially, you would say maybe you know 1 or 2 patients with chronic kidney disease, but every day you see patients with several patients with chronic kidney disease. And if I'm going to pose this here, if I say 1 in every 10 people in this room has chronic kidney disease, what would you feel about it? I mean, the thing is whether you actually know that you have CKD or not. Have you been screened? We don't know. So one of our major problems as nephrologists in this country is, number one, we're taking too long to diagnose our patients. And even when we diagnose them, we're taking too long to start some therapy for them. Now, there was a very big crisis because for the longest time, there was nothing to treat patients who had chronic kidney disease. And even if we had some information about RAS inhibitors, it would improve, slow down progression of chronic kidney disease, but it was not changing the outcomes in terms of mortality. Fast forward to 2022, when KDIGO is our global, you have ADA, you have ESC. For us, we have KDIGO, which is our global, it's a global platform that gives us guidelines as nephrologists on what we need to do for various patients in care. So in 2022, we were a little bit late to get into the bandwagon, but in 2022, we had a global recommendation from KDIGO that says every patient who has CKD, you need to consider an SGLT2 inhibitor, and there was a lot of evidence. Now, I'd like to just show you that, you know, in 2001, the only study that we had that was showing that, that had anything that was giving an inclination that there was something that can slow down progression of kidney disease was the renal study, which was comparing losartan to placebo. It showed that you could reduce CKD progression by about 19%, but other than that, there was no change in mortality, nothing else. Fast forward to 20 years later, we had the DECLARE-TIMI. Initially, this study was looking at heart failure for patients with diabetes. But when they looked at their secondary outcomes, which was the renal end composite, let me break it down and say, the renal end composite is this drug that you are giving. Does it change the course of the course of life for the patients who have chronic kidney disease? Number one, are you able to slow down the process of chronic kidney disease? We know all of us, as we grow older, our kidneys grow older. But if you have diabetes, hypertension, you're a smoker, you take a lot of alcohol, your GFR will come down faster. But now, there's this thing that is showing us that for patients who have diabetes and they have also heart failure, there's a drug that can actually slow down progression of kidney disease by 50%. Within the same year, in DAPA-HF, you know that during the DECLARE-TIMI, it was a signal that there was something happening. But this was confirmed within the same year in the DAPA-HF study, where there was a marked reduction in slowing progression of kidney disease. And soon after, we had the big study, the DAPA-CKD, which has really changed practice for us as nephrologists. And here there was a marked reduction in the slowing down of kidney disease by 39%. Imagine if you have a patient and they're at risk of kidney disease and you can reduce that by 39%. That had never been seen, and that's an amazing thing. And because of this, there were several other studies that came afterwards. We had the EMPA-Kidney study, which came and complemented the findings of the DAPA-CKD study. And after that, we wanted to push the envelope a little bit because nephrologists are a bit adventurous. And we wanted to see, for all these studies, they had looked at patients with eGFRs of 25 and above. And we wanted to see, for patients who have eGFRs of between 10 and 30, can we still get this protective effect? Are you able to prevent your patient from, getting into dialysis? Are you able to avoid transplantation? And yes, the DAPA Advanced CKD actually showed that we could prevent this from happening. And the only thing is that after dialysis, once you start dialysis and once you transplant the patient, we still do not have evidence. So what am I saying is that we have really struggled. From 2001, we're in 2025. It's taken us so long to find something that actually can slow down progression of kidney disease, and we are very excited. So what is the big takeaway home from the FOXIGA? Number one, you're able to reduce the risk of getting complications of kidney disease and progression of kidney disease by 39%. And all you required were 19 patients. 19 was the number needed to treat. That's a good outcome. If for every 19 patients that I treat, I can avoid the bad outcome of death, dialysis, transplantation. We don't want to dialyze patients. So that's a very big thing for us as nephrologists. So coming back to this discussion where the endocrinologist has said, what the effect of this drug has been, and the cardiologist. For me as a nephrologist, my big major take home is that SGLT2 inhibitors should be adopted. Everyone should learn about them. We should learn the complications, and we are going to be able to extend our patient's life and avoid things like dialysis and transplantation. So that I'm a bit practical, I'd like to discuss a case. So FOXIGA has shown very good benefit for patients both in the cardiac and renal spectrum of disease. And in all our patients who have CKD, we know the heart and the kidney work well together, and when we have problems in the heart, we also have problems in the kidney, and vice versa. So my last thing is a take-home message, because this is a question that has been asked by several colleagues here. Is there a difference between empagliflozin and dapagliflozin? Well, they're both SGLT2 inhibitors and they work the same way, but there have been no head-to-head studies that tell us that this that you can directly compare. But what we can see in the trials is that for DAPA-CKD, which was a major trial for nephrologists, is that they looked at a 50% reduction in CKD. So if your GFR is 80 can we prevent you from getting down to 40 and have it sustained below 40? But for the empagliflozin, they looked at a 40% reduction. The other thing that you could see from the two studies, the DAPA-CKD study actually showed mortality benefit. How many people want their patients to die? I'm not putting my hands up, I'm just, how many want to? So DAPA-CKD actually showed a mortality benefit, and that was neutral in the empagliflozin study. So, well, maybe we wait and see if there's anything that's going to come up in the later trial that's going to come up. But that's an important thing to think about going forward. So as a take home, if there's anything you're going to take home from this, is that you need to know your SGLT2 inhibitors. And for the study, the DAPA-CKD study that changed trials and practice for nephrology, there's a 39% reduction in avoiding complications, kidney complications for our patients. And thank you very much.
So thank you so much, Dr. Joyce, and very, very key. So remember, if you compare your diabetic patient with age and sex matched non-diabetic patients, the mortality risk is threefold, okay? If you compare your age and sex matched non-diabetic patient with a patient with diabetes and macroalbuminuria, that means that their USCR is more than 30 or 300 milligrams per gram, it's ninefold. So very, very important. We've come from cardiovascular benefits to benefits in heart failure to benefits in retarding the progression of chronic kidney disease in these particular drugs. So I'll just quickly summarize in terms of safety. Number one, these drugs are safe. We've had extensive data from 10 years. Rates of UTI are very low. Just simply let your patients know that they have to have, in terms of hygiene for female patients, try and avoid them in people who have risk of recurrent UTI, men who have BPE, for example, or people who have strictures and issues like those. Genital infections, no significant statistical increase in terms of if you compare them with placebo. Volume depletion, key thing, let your patients in the months of Ramadan know about increasing their water intake. But again, in heart failure, CKD, have guidance about the maximum fluid intake from your cardiologist and your renal specialist. Amputation risk, with a negative signal with canagliflozin. Right now, we know that drugs can be used in that particular setting, so there are no imbalances. Also with regard to fractures, hyperkalemia, and malignancy. Across board, you can see that's a study across 17,000 patients. You can see also, if you compare them with placebo, look at different outcomes from acute kidney injury to UTIs to diabetic ketoacidosis to amputation, not much difference with regard to increased risk with placebo. Compare them with other class of drugs. Dr. Abdullahi asked us about what do you start first, depot inhibitor or SGLT2 inhibitor. You can see that the drugs are very safe in comparison to this particular class of drugs with regard to hypoglycemia risk and all adverse events. Compare them with SUs, definite benefit in terms of reduced events, in terms of cardiovascular outcomes, all-cause mortality, and definitely lower risk of hypoglycemia, and definitely they have weight loss benefits of up to 2.4 kilograms, as we explained to. So the drugs are safe. Be comfortable starting them. Key take-home points, where not to start them. Number one, any patient coming into your critical care unit, be it due to sepsis, RTA, stroke, heart failure, myocardial infarction, please use a basal bolus insulin strategy for your patients who are in the inpatient setting, especially in critical care. Young patients, your ladders, lean, young patients, 30 years, not obese. Think about autoimmune cause of diabetes, not indicated in the setting of type 1, or your ladders. So again, don't use these particular patients. Very, very important, and most important, your patients going to surgery. Preferably stop the drugs 3, now they say 7 days. But at least 3 days before surgery, please ensure your patients don't go to theater for any particular operation when they're on these particular drugs. They are seen by the physician or the anesthesia clinic. Stop the drug 7 days in advance if they have other things like antiplatelets, anticoagulants, but do not let them go to surgery because of the risk of euglycemic DKA. So that brings us to the conclusion of our session. I want us to all thank our panelists today. Let's start with Dr. Mohamed Abdullahi. Stand up. Thank you so much for that wonderful presentation. I want to ask you to stand up. Dr. Jeilan. Thank you so much. And Dr. Joyce. Thank you so much. And also Godfrey Ayuka, thank you so much for sponsoring this session and for the team putting it together. Dr. Roslyn actually is one who helped us coordinate all these particular interactions to make sure to keep time. So thank you so much once again. So I'll now hand over back to Dr. Jacqueline to get us on the next activity. You can come down, yeah.